Everybody, and good morning. Hello everyone, and good morning to our session on the impact of COVID. We've got 5 papers for you this morning, and we've only got half an hour. So our plan is that we are going to play all the presentations back to back, and then hopefully we'll have the 5 minutes at the end to take questions. Please do put your questions in the chat box, and when doing your questions, please can you write the name of the presenter first. That will help us field the questions. And then myself and Neil, we will be in the background moderating the questions, and hopefully it'll be a really good session. If we run out of time, do you make use of the network lounge to ask any more questions? Okay, let's have the first presentation, please, Neil.
Without further ado, I'll run the first presentation.
Thank you, BritSpine, for this opportunity. My name is Sai. I'm a Year 6 medical student at Peninsula, and I'll be sharing with you our mirror survey study that looked at patient and neurosurgeon perceptions of virtual neurosurgery consultations at our local institution. So there's been a global shift in virtualization due to the COVID-19 pandemic, particularly in neurosurgery. At the same time, there's been a lack of insight into what patients and neurosurgeons think of this change. With our study, we wanted to elucidate the perceptions of patients and neurosurgeons following their virtual neurosurgery consultations, VNCs. At the same time, we wanted to see whether we can generate a guidance algorithm that can tell us a little bit about when to use and when not to use VNCs. So what we did was construct a 10-item qualitative and quantitative survey and distribute this to patients and neurosurgeons following their VNC, virtual neurosurgery consultation. There was strict inclusion criteria for neurosurgeons, whereby only those who had more than 3 VNCs under their belt were surveyed. And this left us with a sample size of 106 patients and 10 neurosurgeons. So this is an unequal sample size because it's a local study and also because of the strict inclusion criteria. So we use non-parametric hypothesis testing to analyze the quantitative Likert scale data and grounded coding with intercode agreement to analyze the qualitative data. So this is the quantitative data. Overall, what it tells us is that patients perceived a more positive experience with VNCs in the following domains: satisfaction, preferences, quality, confidence in use, effectiveness, and willingness to use. Of particular note would be the last question, where over 90% of patients agreed that VNCs have the same qualitative information, provide the same qualitative information as face-to-face, whereas that figure was 40% when the neurosurgeons were asked the same question. With the qualitative data we have here, the following themes were generated from the grounded coding: efficiency, communication, safety, technology, admin for patients. And the neurosurgeon responses were pertaining to safety, efficiency, and communication skills. So the inability to examine is a big component when we discuss VNCs, and that came out, that was categorized as safety through ground coding. And we can see here on the right, overwhelmingly, in terms of comments pertaining to safety, overwhelmingly they were about the examination for neurosurgeons, whereby they said, we can't repeat, we have to repeat consultations because we can't examine, and also we cannot do a risk assessment. Patients on the left here as well, they also identified the inability to examine. At the same time, there were responses pertaining to a positive safety profile with VNCs, in that it's reduced COVID risk and also reduced pain avoidance. This is understandable with those who have chronic pain. For VNCs, they can do this from the comforts of their bed or their armchair. And finally, this is the last results slide. When we look at the suitability responses, what we see is that we can potentially consider VNCs for post-op reviews and scan result discussions, and they likely have limited utility for new patients and new onset neurological deficits because of the examination component largely, but also neuro-oncology because there's a perception relating to the Breaking Bad news and sensitive discussions. So we have an unequal sample size, as highlighted earlier, because it's a local study and the strict inclusion criteria for neurosurgeons. And also there's a sample bias in that we only surveyed patients who were offered VNCs in the first place. Going forward, there are several things to consider. Pre-VNC tutorials are something that have been used in the States, whereby patients have these tutorials and essentially where before the VNCs, and in these tutorials they're basically trained to check their bandwidth, they're advised on the approximate waiting time, and also there's instructional videos about self-examination. And this table we've shown here, we feel potentially is of use for neurosurgeons starting off using VNCs, and also managers starting off with VNCs. These are our summary of our results, but ultimately, it's of course, neurosurgeons must exercise clinical discernment when to use and when not to use VNCs. Thank you again, BritSpine, for this opportunity, the references, and thank you for listening.
Good morning, everybody. My name is Mr. Riaz Mohammed. I'm a senior spine fellow currently working in Cardiff, and I'll be presenting a multi-center BAS collaborative study looking at restoration of elective spine surgery in the UK during the COVID recovery phase. Centers that have resumed elective spine surgery have done so by creating patient pathways in accordance to the resources available in those units. What facilitated this process was the abundance of national and specialty guidances, for example, the BAS guidance, the BOA, Royal College, or the NICE guidance, to name a few. This enabled creating local patient pathways that involved patient prioritization, risk stratification, patient information and consenting about the added risks of COVID, and significant resource restructuring. Given that there are significant complications of COVID-19 infection in surgical patients, we conducted a multi-center collaborative study to look at the clinical outcomes of elective spine surgery at the reintroduction phase of the pandemic. A study proposal and data collection pro forma were personally communicated to multiple spinal centers in the UK. Within the time frame of the study, we obtained responses from 6 centers, 4 from England, and 1 each from Wales and Scotland. All units were encouraged to collect data within the framework of clinical governance and service evaluation. All adult and pediatric patients who underwent elective spine surgery were included. Any clinical reason where the planned surgery had to be performed as an emergency or test-proven COVID positive patients were excluded. The data collection period was the first 30 days of resuming elective practice, and this varied from unit to unit. The primary outcome measure was the 30-day mortality rate or postoperative COVID infection rate. Secondary outcome measures included surgical or medical complications and length of stay. In total, there were 138 patients from the 6 units, and only 4 of them were pediatric patients. The average workload from each unit was 23 procedures or 23 patients done in the first month of resuming elective surgery. According to the BOA categorization of facilities, almost half of the procedures were done in silver facilities where there was a physical barrier possible for elective spine surgery patients. According to the Royal College prioritization category, 60% of the patients were category 2 and the remaining were category 3 or category 4. According to the CDC BOA risk stratification, almost 90% of the patients were of low or medium risk category. In total, 87% of the patients self-isolated, and almost all patients had COVID swabs done preoperatively. Most common indication for surgery in this period was degenerative spine conditions. Looking at the primary outcomes, none of the patients were diagnosed to have 30-day postoperative COVID infection. However, 13 patients required swabs done for clinical indications. All of them turned out to be negative. There was 1 mortality in the study period, an 88-year-old lady who developed postoperative chest infection. She had a COVID swab which was negative. However, she was diagnosed to have widespread metastatic renal cancer. 20 patients in total developed 23 complications. Majority of them, 75%, were clavin-dindo grade 1 and 2. These are complications that can be managed in the outpatient setting or on the ward. 3 patients, however, had surgical complications that needed a return trip to theatre. None of the patients required care escalation to a critical care setting. The median length of stay for the cohort was 3 days, but majority of the patients were discharged within 1 week. There is published evidence from other centers in the UK where elective orthopedic surgery was safely done with low COVID mortality or morbidity, but to our knowledge, no such evidence was seen for elective spine surgery patients. As we continue through the pandemic, restoring elective spine surgery requires a dynamic and flexible working posture from individual units, along with a diligent monitoring of clinical outcomes. It is important to ensure that the systems and provisions are in place to ensure elective spinal surgery can be continued in a safe manner, both for our patients and the staff. Our study shows that despite variations in infection prevalence rates and service provisions across the UK, there is very low risk of hospital-acquired COVID infection in elective spine surgery patients. The study provides valuable information for shared decision-making for our patients and adds confidence both for patients and the healthcare professionals that planned spine surgery procedures can be done in a safe manner with appropriate infrastructure, following COVID-secure patient pathways under robust clinical governance arrangements. Thank you all for your attention.
Spinal rehabilitation during coronavirus restrictions, challenges and experiences of piloting a virtual back group. I'm Ruth Newsom, a spinal extended scope physiotherapist from Sheffield. The current evidence base for treating low back pain recommends group exercise. The back group we had could not be delivered in COVID. We have recently commenced a virtual group through a long process of pilot trials, and I will outline what we did to achieve this. This is what we had prior to COVID. The patients had functional rehabilitation in line with their agreed goals. Data demonstrated improved outcomes. COVID-19 put a total stop on group work. We felt very strongly that it was important to explore ways to maintain the service for our spinal patients despite the restriction. If we don't provide different delivery, then potential increase in future back pain and disability is a disservice to the patients. It's an opportunity to explore and modernise delivery for the future. It was personally daunting, but also an exciting opportunity, and decided to run test pilots. We began the long road to providing a virtual service and needed to test equipment predominantly, then ways of delivering meaningful treatment. IT equipment was challenging as we had very little initially and not much experience using it. Attend Anywhere was used as the trust-approved NHS platform. I thought a hybrid group to include 2 patients in the gym and 3 virtual patients to create the group feel might work. No, it didn't. Hybrid at this stage wasn't going to work. It was difficult to coordinate the 2 aspects doing different things. There was huge problems with sound quality and equipment. On a positive side, it was noted that the virtual patients who had exhibited higher levels of anxiety and pain did a lot more movement in the virtual group than individual in appointments, from wanting to sit down constantly to possibly being like a Duracell bunny. Pilot 2 involved another attempt at Attend Anywhere, as like many trusts, we had a definitive non-negotiable no to the Zoom platform. Attend Anywhere is limited to 6 participants, so we could only have a maximum of 4 patients with 2 members of staff. We had visual freezing on screen. We had a large screen, but the sound had a time lag, which was interesting, but difficult to get meaningful engagement. A fitness instructor was in attendance with the patients, and we did exercise demonstrations. Physio patients' feedback on content suggested a physio-led session rather than a general class was better for reassurance on technique and movement. They liked the idea of a fitness instructor attending at times and suggested that 30 minutes exercise was enough. They also commented that they thought Zoom was easier to use. Microsoft Teams was approved for a 3rd pilot to be tested using the Trust Pro Forma for its use. We had better equipment in the form of a large screen and soundbar, which made a big difference. 2 participants struggled with getting logged on and admitted, one of which had a very old computer that wouldn't download Teams. It isn't just the clinicians that are grappling with IT. We could test it with more participants. Feedback was very positive with sample exercises performed. Patients were asked if they would like information or question and answer sessions within the group. They thought this was good as an optional 15 minutes at the end. Model 3 was taken as the pro forma, and there was elation at having finally led a virtual back group with functional exercise using home equipment. Granted, this consisted of carrier bags, weights in any form, tins, water bottles, and picking up balls of paper to throw to practice bending and lunging. We now have funding approved and equipment installed in department, which makes the programme delivery much more efficient than the travelling spinal roadshow we did, finding department that would lend us facilities. This gives us a lot of opportunities even after physical groups return eventually. There were some surprises, patients doing more in a remote setting. It's easier to co-work with different disciplines with reduced travel and time constraints, and has helped our journey towards delivering a combined physical and psychological programme. There may be opportunities to co-work with spinal service providers in other regions, joining in virtual back group rehabilitation to share resources and co-working with out-of-area patients. Patients have more options for treatment open to them, combining both physical and virtual treatment. If anyone's interested in any resources or the type of exercise we use, please message. Thank you.
Hello, my name is Antonia Isaacson. At the time of this study, I was the Senior Spinal Fellow at Sheffield's Teaching Hospital NHS Trust. This study looks at the impact of the first national lockdown in the COVID-19 pandemic on the emergency referrals to Sheffield's Adult Major Trauma and Spine Centre. This centre services about a 1.5 million population and receives both direct referrals from accident and emergency and the local community, and also tertiary referrals from 5 surrounding hospitals. As COVID-19 cases increased in early March, on March 17th, there was a national directive to stop any elective surgery, and only emergency surgery and services should continue. On the 23rd of March, there was also the first police-enforced national lockdown, which prevented anyone from leaving home except for exceptional circumstances and as key workers. Emergency spine referrals make up a significant proportion of the work performed by Sheffield Spine Centre, and this study sought to establish the effect of lockdown on the rates and types of referrals that were received by Sheffield Spine Centre. We collected data retrospectively between the start of January and the end of July of 2020, and we looked at the type of pathology and the mechanisms of injury when relevant for these referrals. A total of 1,156 patients were assessed within this study, and when divided down to time periods, we noticed there was a reduction in the number of overall referrals received during the lockdown period. Now, while this was reduced, it was not statistically significant. I then broke these down into the types of referrals, and it was noted that there was a reduction in both direct and also tertiary referrals during lockdown. Again, this was not statistically significant. When we broke this down onto a patient referrals on a weekly basis, it was, however, found that there was a significant reduction in the number of referrals from both direct and tertiary referrals during the first month of lockdown. These referrals quickly rebounded to pre-lockdown levels. When we divided these referrals up based on pathology, we found that the most significant reduction was in the atraumatic group. This is things like cauda equina, those referrals made due to osteoporotic fractures, those due to cancer conditions. There was also a reduction just for the first month, but to a lesser extent in both high velocity trauma and in low velocity trauma. Interestingly, throughout the entire lockdown period, however, there was a reduction in the number of referrals for patients who actually had no underlying pathology. And I think this represents the effort made by all departments to prevent unnecessary admissions during this time period. When we look at the types of referrals for the atraumatic group, the proportions remain the same. So during pre-lockdown, the first month of lockdown, and after that, we noticed that cauda equina always makes up approximately half of the referrals. Those referrals in relation to cancer make up approximately a quarter. It therefore seems that it was the overall number of referrals that were reduced rather than any specific type of group. When we look at the high velocity trauma, there was a reduction in those that had pathology as a result of high velocity trauma caused by road traffic accidents. Falls from a height greater than 2 meters, however, remained approximately constant. When looking at low velocity trauma, falls from a standing height continued to make a significant proportion of this group throughout all time periods. So to conclude, there was a 21% fall in emergency referrals during the first month of lockdown. These emergency referral rates quickly rebounded to pre-lockdown levels, however. The biggest reduction was those from patients self-presenting. I think this reflects both the population being scared to present and also clear communication saying that emergency services were still open for when necessary. Thank you very much.
Hello and welcome. I'm Rory Fairhead from Oxford Medical School. Today I'm presenting our paper, The Safety of Corticosteroid Injections During the COVID-19 Pandemic, a retrospective observational study. This is on behalf of our research group as listed on the bottom left. As many of you will know, corticosteroid injection involves targeted administration of various formulations of steroids into various sites in the body, largely joint capsules, in order to reduce pain and inflammation at the site. In the context of COVID-19, steroids are immunosuppressive, so could theoretically increase the severity of COVID-19 infection. This theoretical risk led to various national organisations to issue guidelines to reduce steroid dose and to avoid performing these injections except in exceptional circumstances, at least at the start of the pandemic. So why this initial caution? Corticosteroids increase the risk of many infections in a dose-dependent manner and suppress the body's immune response to various pathogens by inhibiting T-cell responses and several interleukins. They suppress the immune response to several common viruses, but may actually decrease the replication of certain types of coronaviruses. Our study aimed to investigate practically whether corticosteroid injections led to increased COVID-19 morbidity. Using electronic medical records in the Buckinghamshire area, we identified patients who had received corticosteroid injections and then cross-matched them against records of COVID PCR tests, antibody tests, and radiological investigations that could indicate COVID infection. As you can see on the top right, the number of injections dropped off quite considerably as COVID caseloads increased, shown in the bottom right, in the initial phase of the pandemic. This was as injections were limited to the most severe cases. This also shows how the type of corticosteroid injection performed was guided by different methods. So most of the injections were either CT or ultrasound guided. This would have necessitated considerable contact with the hospital environment, which would potentially have increased the risk of COVID further. The population investigated were largely white and female and over 50, with a relatively low representation of BMAE populations. We found that out of 504 injections performed, only 2 patients then showed any evidence of COVID-19 infection. These were both via an IgG antibody test. 11 had PCR tests, all of which were negative, and 12 patients had radiological investigations, one of which was a CTPA, which had COVID-like findings that later thought to be unrelated to COVID. So how can this data be interpreted? We found that the rate of COVID pickup in our population was lower than the estimated COVID infection rate in the Buckinghamshire population over the study period, which was around 6%. This very low incidence cannot be meaningfully interpreted, however, as it is very likely that asymptomatic and mildly symptomatic cases in our study population were missed due to the lack of mass testing at that point. However, adverse outcomes requiring hospital admission would have led to COVID testing and thus the identification in our study. The fact that we found no such patients who had adverse outcomes following corticosteroid injection is a significant finding, indicating that the careful use of corticosteroid injection is appropriate during COVID. There are multiple limitations to our study, notably that the sample size is quite small and that corticosteroid injection recipients may have taken steps to reduce their COVID exposure, and also that we may have missed positive cases if they were conducted privately. As well as a larger study of this type, future research is needed into the effect of corticosteroid injection on vaccination response. We're also conducting research into the service disruption caused by the pandemic and what solutions could return this to normality. For more information, please see our paper on the topic, which has been published in Bone and Joint Open. Thank you very much for listening.
So I'd like to thank all the presenters for their high quality presentations, in my opinion, on what is a very unique topic, and certainly good to see the first bits of research coming out related to the COVID experience that we've all had to go through. We are a bit light on questions, so you've obviously all got your points across very well, and I thank you all for sticking to time, although it would have been difficult not to under these circumstances at least. There is a question from Martin Wilby for Rory. He'd be interested to know how the BPS will respond to the data. Do we have the presenters back in the? Are they able to respond?
Yes, we do. So all of the speakers are invited as presenters. So if you'd like to turn on your microphones to respond to any questions, please.
Thanks, Henry. So 2 questions. Rory, are you with us?
Oh, yeah. Hello, can you hear me? Sorry about that. Couldn't quite work out how to turn on the microphone.
No problem. No problem. We're all getting used to it. Don't worry, Rory. Martin Wilby says, great paper, but he'd be interested to know how the BPS will respond to the data that you've presented.
Is that the a pharmacological society or the psychological society?
That's a good point. I can't answer that question for you. Maybe you want to answer both.
Well, I suppose, I mean, probably from the pharmacology perspective, I think that the lowering of doses wasn't necessarily backed up by by any kind of society. So I think it was done very much kind of at the whim of the radiologist. And in terms of the sub-analysis of the steroid type or dose, we didn't do that because I think the majority of the injections were of one particular dose, and there wasn't really quite enough data to look at the different kinds of steroids and doses used.
Thanks for that answer, Roy. And I think that also answers Ed Seal's question about a sub-analysis of steroid type or dose. We're running very short of time. I don't know whether I can we squeeze any more questions in, or? Do we have to stop, Henry?
I think we need to stop now, or we've just gone over the 12 o'clock mark.
So once again, thanks to all the presenters. Thanks also to Susie for co-moderating this with me. She's been a great help for a technophobe like myself. And I hope you all enjoy the rest of the conference. Bye.